Good morning. So we are at 42 degrees and 6 minutes north and 102 degrees 5 minutes west. That is the location of this place. This is Kolkata, the city of joy. You know, this is home to so many Nobel laureates, starting from Rabindranath Tagore, Ronald Ross, discovery of malaria, C.V. Raman in physics. We have got Amartya Sen in economics and Abhijit Banerjee in economics. Oh, you thought I had forgotten somebody, didn't you? Of course, Mother Teresa. But when Mother Teresa was in her younger days, I'm sure she would have seen much clearer skies than what we have seen now. Today, fortunately, it's quite a clear day, but we will investigate the pollution, the environment, and therefore the diseases that it brings, chronic obstructive pulmonary disease, and of course, diabetes. I'm going to now go to pick up my friend and an eminent pulmonologist of this city, and indeed of India, Dr. Raja Dhar. So come with me. So now the sun is rising up in the sky. I don't think you can see it, but I can see it. So we are going to meet another rising sun. And I would be wrong in saying rising sun. He's already up there in the sky as an luminary in the field of pulmonology. So Dr. Raja Dhar, he is a consultant in chest medicine in C.K. Birla Group of Hospitals. He has had extensive training in the United Kingdom and has returned to India more than 10 years now and has done innumerable research in the field of pulmonology and is a leading pulmonologist not only in the city of Kolkata but also in the whole of India. So it will be my pleasure to introduce Dr. Raja Dhar to you. So let us meet him now. Hello, good morning, Raja.
Good morning.
How are you? How are you?
Very good.
It is
so nice to see you after the COVID times outside the hospital.
It's the first time after COVID we are meeting outside the hospital.
Indeed. Very first time. It's lovely, isn't it?
It is.
It's
and you're looking
reasonably
different
sunny.
also.
Without the PPE.
Without the PPE. That's it. So let's go.
Let's go. Let's make a move. So, you remember the COVID times, Kolkata? It seems a distant memory today. The sun is up, we are not wearing PPE, there isn't a mask on the face, and it's almost empty, this place. Compare this with April, May last year, when all we saw was clouded images through a PPE. The glasses used to be completely foggy. You know, you remember those times?
Terrible. Absolutely terrible. And I remember you had more than 120, 130, or God knows how many patients, and of which are about 80 to 90 were with hyperglycemia.
Correct.
So
Correct.
that was a real tough time.
So hyperglycemia, and a lot of these people also had chronic lung disease. And in our country, with chronic lung disease, you think of COPD. So the overlap of COPD and diabetes at this time was enormous, which is why we managed to work together through these difficult times in April, May. We've done that even at other times, but April, May, I think was memorable, wasn't it?
That was particularly memorable because one begets the other. And as you know, with diabetes, you have got 3 times more risk of having severe COVID, 3 times risk of dying with COVID. And also there is quite a bit of evidence now that if you have got lower HbA1c, then your risk of having severe COVID reduces significantly. At that point of time, we didn't know, but now we definitely know. And it was extrapolated from other infections as well. So somebody having HbA1c close to 10% had a very high risk of having severe COVID as opposed to somebody having 7%. And it seemed that 8% was the inflection point beyond which the severity increased. So we all strive, diabetologists, we really strived hard to get the blood sugar under good control.
Sure.
Not only during the COVID, but patients who were at risk of having COVID as well. But as you said, the inflammation-based bit seems to link both of these together.
Sure. Well, all three together, isn't it? I mean, I think we learned so much more about inflammation, lung disease, worsening diabetes during the COVID times. So the common thread, as you said, is inflammation. And you know, the common thinking, we don't know for certain as yet, but the common thinking is that people who have COPD have inflammation in the airways, inflammation in the lung, and especially during an exacerbation, but even with severe COPD, this inflammation spills over into various organs. And when it spills off into various organs, your diabetes gets worse, your hypertension gets worse, your chronic kidney disease gets worse, the chronic heart disease gets worse. So it hits various organs. And there's a link, isn't it? And I know we'll discuss this even more later on, but there's a link between controlling the inflammation in COPD and hence controlling diabetes, and controlling the diabetes and hence controlling the COPD, correct?
Yes, I think there's definitely interplay between the two. So if you look at COPD begetting diabetes or worsening diabetes, as you have rightly said, the inflammatory milieu, the IL-6, the TNF alpha, all of those are responsible because they are common. They have share commonality with diabetes inflammation as well. Plus, in COPD, I've got hypoxia causing malfunction of the organs. That begets reduction in mobility, which reduces your ability to reduce the blood sugar. Plus, you have got steroids as well. And on the other hand, if you look at diabetes, diabetes has got microangiopathy as well, which might affect the pulmonary capillaries. So that might impair the diffusion. Diabetes itself can reduce the workload of the, reduce the muscle power of your respiratory muscles, autonomic neuropathy causing it. You have got advanced glycosylated end products in the receptors, RAGE, so receptor for AGE, advanced glycosylated end products. Those are affected because those have a role to play in your T helper cells, T helper 1, T helper 2 cells. You see, with the diabetes affecting the COPD, you know, you have got affection because of the autonomic neuropathy, the muscles getting affected. You have got the central baroreceptors and high carbon dioxide level pickup that is affected, the hypoxia level pickup that is affected. You have got studies to show that the FVC, FEV1 is slightly reduced in patients with diabetes as opposed to those who have non-diabetes, even if they don't have COPD. So that is pre-existing as well. Sure. And also there is some reduction in the diffusion capacity, and that primarily with hypothesis is that it might be due to the microangiopathy. Sure. Because pulmonary vasculature is a big area of blood vessels. It affects the microangiopathy, and that might affect the diffusion as well. So big areas, and this we are talking about big groups of people. So is it relevant to our day-to-day practice? How common is COPD and how common is this combination?
No, it's fascinating what you're saying, Kolanda. I think the fact that you mentioned that even without COPD, your lung function gets impaired, you get smaller lungs if you have diabetes because of the microangiopathy. But like you said, if you just think about the prevalence of COPD in our country, let's try and think of some numbers, and they're mind-boggling numbers. So if you think about 1990, the total number of patients with COPD in the country was a guesstimate of about 28 million. So 28 million in 1990. 2016 global burden of disease data, the number is about 55 million. 2021 global burden of disease data, it's something like 65 million. 65 million. So we always know that India is the diabetic capital of the world. But I would argue that it is also the COPD capital of the world. You know, we have pushed COPD from being the second cause, the third cause of mortality throughout the world, to being the second cause of mortality throughout India. Then there's the overlap with ischemic heart disease, which goes along with this gamut. So this metabolic syndrome bit, and I need to remember and discuss a case with you, which I think is relevant to this. However, if you think about metabolic syndrome, where there's heart disease, there's obesity, there's sleep apnea, there's diabetes, there's COPD, it's all linked together by the inflammatory cascade that you spoke about. It's linked together by all the vascular changes that you pointed out. And hence, even with heart disease, we are the capital of the world. So it's a gamut of changes, isn't it? It's about diabetes, it's about COPD, it's about heart disease, kidney disease, etc. What about overlap? So I was reading some data a few days ago for a different presentation, And various studies have described this overlap between COPD and diabetes to be somewhere between 2 to 37%. However, there are some studies in Europe which actually rate it even higher at about 50%. So the mean studies are about 15 to 20%, which means that every patient, for every 5 patients that I see with COPD, one would be an uncontrolled diabetic. So that's a large number. And I think we need to remember that. And that's why people like yourself and myself working together makes a large difference.
And not only that, you have said about 1 in 5 having diabetes, but for every person with diabetes and another person who has got diabetes, one not been diagnosed. So that's a big chunk. And the studies which are there are all from the Western Hemisphere. We don't have that many studies from our Indian subcontinent because you see, I think this problem is far worse here.
Absolutely agree.
See, like, so I have worked in England, you have also worked in England. In the Western world, from the diabetes point of view, what I've seen is in the foot clinic, it is populated mainly by white Caucasians, whereas the
Sure.
heart clinic
Absolutely.
is populated
Asians.
by Asians.
Asians,
So
correct.
therefore, I think the COPD bit is the same for COPD, I think. So I think the problem which we have said is perhaps much more in our country.
Correct. One of my images of Prinsep Ghat, along with seeing it on a regular basis, is the movie Parinita. You know, in Parinita, we saw Sanjay Dutt and Vidya Balan in front of Prinsep Ghat, and the images still stick to mind. It's a lovely place, this. I mean, we are here in the daytime, but especially at night, it looks very nice when it's lighted, isn't it? I'm sure you've come and seen that, Kullanda.
It looks as if you are entering into a palace or something.
Correct.
Is that what they showed in Parinita?
That is correct. I think they used it more as a backdrop for a palace rather than showing it as Prinsep Ghat. This is one of the places I frequent often. There's a lot of eateries around, as you know, Kullanda.
Okay.
So I know you're also a foodie. So there's lots of eateries around. And it also has very nice images of the second Hooghly Bridge. You know, you can see the welcome up there. And again, I feel, I'm biased towards Kolkata, but I feel this second Hooghly Bridge really epitomizes Kolkata and its spirit and the way it's gone forward over the years.
I think it's quite an impressive one. So the length of the second Hooghly Bridge connecting to the mainland India, if you may. It was because the Hooghly and the Ganga divides it.
Correct.
So,
Correct.
and this is on the backdrop of Prinsep Ghat.
So one of the things which worry me, Kollanda, back to academics again, you see all the pigeons there. I don't know whether our camera person can actually pan towards the pigeons up there. These pigeons cause a lot of chronic lung disease.
Yes.
So while they look very pretty in the background, but the pigeons, if they come near you, if you put sort of, aap dana doge in logon ko, so these people can actually cause a lot of lung disease. And I think that's important to remember for the people who are listening to us. But that's an aside, I think.
As a junior, I think I remember my chest consultant said that the history is incomplete. If you want to take a history regarding lung disease, history is incomplete if you don't ask about pets.
Correct. Correct.
So that really brings out this point. And
So
you know,
chronic hypersensitivity pneumonitis, Kollanda, Indian data, we were talking about Indian data in a different scenario. We were talking about COPD, but this is in the perspective of interstitial lung disease. So chronic hypersensitivity pneumonitis causes 1 out of 2 ILD cases in our country. And that's data very, very different from what it is in the West. And that's why I think you hit the nail on the head when you said that we need Indian data even in the area of COPD, diabetes overlap, or these individual chronic diseases. Very important to remember that.
so when talking about India, we've just come past a gentleman I saw hanging from a tree. That reminded me of a case. We will discuss that.
Correct.
It just reminded me of a case that
Correct.
common to both you and me.
Kolkata has another iconic place. We are here, Kollanda. This is Babu Ghat. So for the uninitiated, Babu Ghat is after Babu Raj Chandra Ghat. He was the husband of Rani Rashmuni. And folklore has it that in 1830, this ghat was primarily built. You can see the Howrah Bridge in the distance, and on the other side, you will see that there's the second Hooghly Bridge, and there are ferries which ply between these two to carry uh, passengers, to carry goods across these two places. So, lovely memories. I'm sure you have
Yes,
some memories here, Kollanda.
sure. I think, Hooghly is a distributary of the Ganges. And it's a big, big distributary. You can see the other side of Bengal, which is Howrah, or right on the other side. And as you've said, here behind me is the old Howrah Bridge, and in front on that side is the new Howrah Bridge, and here in between is the Babu Ghat, quite like Calcutta, which has a marriage of the old and the new, the modern and the traditional.
Right. So let's discuss a little bit more about. You mentioned someone a little while ago,
Yes,
Kollanda,
yes.
the gentleman who was hanging from the tree, and I think it's very spirited. He's trying to exercise. He's trying to lose weight, which is the way all our patients with metabolic syndrome should go. But it reminded me also of a case of a gentleman who looked similar. Wasn't this gentleman, of course, but looked similar. Big paunch, had COPD, and was being treated with us for a very long time in the outpatients. He was not compliant with his medications. He came into hospital every 3 or 4 months with an exacerbation, and you and I saw this patient on multiple occasions. However, the time that you and I remember is when he came in with breathlessness, but more importantly, came in somewhat obtunded. He looked very unwell. He was dehydrated grossly. And when we looked at him, examined him, did an arterial blood gas, we found he had metabolic acidosis and his urine showed ketones. So that's when I called you, you remember, Kollanda, and you managed him. So tell us how you went about doing
Yeah,
that.
it was a 60-year-old gentleman, if I remember correctly.
60-year-old
Yes, yes,
gentleman,
yes. So I
correct,
remember
correct.
that now because why I remember that is that this gentleman has had previous admissions as well because of recurrence, and that's why he came to show you that to break this cycle of repeated admissions. And there was a bit of a gap between his follow-up of a few weeks, and there was some compliance issues with the medication. So this is very important for everybody to pick up in patients with COPD when they land up in infections. So everything is not hypoxia. There can be something else apart from hypoxia. So as here, he had hypoxia and hypercapnia, but as you rightly picked up, that he looked very dry and dehydrated. And one of the causes of dryness and dehydration is hyperglycemia. So you picked up that why is he dry? Well, the blood gas shows marked acidosis, dryness, acidosis, COPD person. Has he got diabetes? Yes. So are we missing diabetic ketoacidosis here? So as we know, we traditionally think that it's only type 1 diabetes patients who get DKA. So we are incorrect in that. Type 2 can also get DKA, particularly in the setting when they shut down their insulin production completely. So this gentleman, remember, he had a pH around about 7.2-ish, something like that, and very low bicarbonate, and they had ketonuria. So we immediately, what I did was, I had discussed with you, looking at his cardiac reserve, his echocardiographic findings, his IVC, we tailored the fluid because the first treatment of diabetic ketoacidosis is giving fluid. But in COPD patients, we have to be mindful of the fluid because they may have heart disease as well. Correct. So you checked his echocardiograph details, you checked his IVC, and you found that actually he was quite dehydrated and his IVC was completely collapsible. So we gave him a lot of fluids, started off with fluids, we started off with insulin infusion, and whenever you do that, you must look at the potassium. That's crucial in diabetic ketoacidosis.
The people who are listening in should remember, and very important, the first is that people with COPD should automatically get checked for diabetes at some point of time because of the increased prevalence, because these patients are on oral steroids on a recurrent basis, especially these exacerbators. So that's one important point. The other important point you said is that these patients with concomitant COPD and diabetes, or people who have COPD and then come in undiagnosed, the way you described or we described in this particular case, they have this vicious cycle. They have an exacerbation. The exacerbation often is triggered by poor control of diabetes. Then exacerbation gets controlled, but they stop their medications, and this vicious cycle goes on. So I think that's an important message for all of us.
I mean, from the COPD point of view, how do you break this vicious cycle? And I'll tell about from the diabetes point of view, few points which have come out from this case, which we can extrapolate to most of the other cases as
Sure.
well. So how will you break this cycle? How would you stop this for this gentleman? I think we can extrapolate this to other people as well.
Sure, of course, Kolanda. And I think the first thing to think about is that we need to educate, talk to our patients and ensure that there's compliance. Unlike diabetes, I know there are non-compliant people even in diabetes, but it is far greater in COPD. And the taboo starts off with people thinking that they become dependent on their inhaler. There's this taboo that if they take a steroid inhaler, then their bones become brittle, their cataract develops, and the diabetes goes haywire. Then there is making sure that whatever inhalers we have given them, they comply with that, they take it in the way they are supposed to take it. So if you've ticked the box of compliance, you've made sure that the inhaler technique is correct, and you have impressed upon them that they remain on the drugs that are prescribed to them and they come back for repeat appointments, the management of COPD is basically based on two groups of medications. One is bronchodilators and the other is inhaled corticosteroids. Inhaled corticosteroids are mainly for recurrent exacerbators, people who exacerbate again and again, who have a raised blood eosinophil count. That's the category of patients where you use an inhaled corticosteroid. However, one must remember that inhaled corticosteroid is a bit of a double-edged sword. You know, inhaled corticosteroids in COPD also seem to increase the incidence of pneumonia. So that's why the category of patients who are exacerbators, large symptom burden, raised eosinophils would be the right candidate for inhaled corticosteroids. So the backbone of management of COPD is bronchodilators. And bronchodilators, as you know, is a LABA or a LAMA or a combination of a long-acting beta agonist and a long-acting muscarinic antagonist. So that's the combination that you use in these people. There's various new drugs that have come in. There are other medications like N-acetylcysteine, low-dose macrolides, etc., which reduce exacerbations, but they're not sole treatment. The sole treatment is bronchodilators, either singly or dual bronchodilators, with or without inhaled corticosteroid in a select few. There's another concern about diabetes and inhaled corticosteroids, and you know that the recent meta-analysis showed that inhaled corticosteroids don't really push up your sugars. What happens if you don't take the steroid when it's indicated, the inhaled steroid I mean, the chances that you need oral steroids in an exacerbation is more, and hence the hyperglycemia becomes worse. So that's, in my book, the understanding about COPD management and how you prevent exacerbation. What do you do in all these patients? I mean, you look after about 70 to 80% of my patients, Kolanda, who also have diabetes, new diagnosis follow-up. How do you manage these patients, especially when they come in with an exacerbation and are on steroids?
Yeah, so I think the recurrence bit you have said for this particular gentleman, so was having recurrent, and this admission, I think the hyperglycemia had a very big role to play for this admission, for this readmission, shall I say. Now, I think, so in patients who get readmitted, or I see that they do get recurrent courses of steroids. So first, as you said, education is the key. So first, explaining to them that these are the group of medications, i.e. the steroid, and these are the names. So it is perhaps a good idea to keep the trade names of the steroids which are available in our practice. Keep it in a piece of paper and tell the patients, whenever, wherever you are started on these group of drugs, your sugars are likely to go up. Immediately contact your diabetes team. That's the first thing, because so often I have seen that steroids are initiated, that is not done, blood sugar goes up, infection, diabetic ketoacidosis, and you blame that, oh, the doctor has given me wrong treatment because he started the steroid unnecessarily. He may not have started it unnecessarily, but the right steps were not taken to reduce the hyperglycemia. So giving the names of the steroids and then keeping in your mind what would you be doing for this particular patient should he or she be started on steroids. So I think that's the first thing. Second, giving them the target for the HbA1c, explaining to them that good glycemic control will reduce the risk of infection, and if they get one, that will reduce their outcomes, their bad outcomes. So names of steroids, what all things can worsen their blood sugar level, what should be their target HbA1c, what should be their target fasting and PP sugar, regular checkups of their blood sugar, monitoring of their blood sugar at home by using glucometer. I prescribe it more often for patients with COPD because they can check it themselves, because they might be reluctant to go and do it in the lab. And in the COVID times, that was even more challenging. So no need, you check it ever so often. Every 3 months you go and do it in the lab and you double check it. So monitoring of blood sugar to find out that your blood sugars are not going haywire. If they are, then you come to us early.
Sure. And this close coalition that we have, the close relation we have as professionals, is also because we come down on this dose of steroids, isn't it? It's not just one dose of prednisolone 30 milligram or methyl prednisolone 40 milligram 3 times a day. The dose changes, and that's the challenge, isn't it? That's why we need to collaborate, because your requirement for insulin or the oral hypoglycemics will also change as the dose of the steroids come down. So how do you go about doing that, Kullan?
So absolutely, Yasin. So remember, so you knowing about the PK/PD data about the steroids, so you start somebody on hydrocortisone, we know that within 2 or 3 hours the blood sugar is going to go up, and one a single dose in a 12 hours time it will come down. But if you're using methylprednisolone, that's somewhat longer, both of them. If you're using dexamethasone, even longer, and it will come down about 24, 48 hours after you stop the dexamethasone. So knowing that is very important. And I will discuss that about the steroid and blood sugar control with steroid-induced diabetes as well in a bit more detail. But another important point is, when you are coming down on the steroid, many patients I know have landed up in hypoglycemia. Again, explaining to them, your blood steroid levels come down, your insulin or your medications must come down. Regularly check your blood sugars at home. That's the key. Otherwise, you will be all at sea. You will never be able to adjust the medications. You will end up with either hyperglycemia or with bad hypoglycemia.
So with this patient, I think what happened, like you said, was that with the sugars coming under control, the acidosis getting controlled, the respiratory distress also got better within a short period of time. We did not treat this patient with steroids on this admission because the main issue here was the dehydration, was the diabetic ketoacidosis, and the patient went home without steroids, on inhaled corticosteroids only, along with the long-acting beta agonist and the long-acting muscarinic antagonist. And I think that's an important point. It's not all or none for every patient. There's no tailor-made treatment. For this patient, the diabetes was much more important than the COPD exacerbation, and we tailored treatment accordingly. And another thing I think very important, something that you said, Kolanda, which the people listening in have to remember, for any chronic disease, but especially for diseases like COPD and diabetes, education, counseling, partnership with your patient and their family in explaining things, and then maybe some amount of home monitoring is important. Otherwise, we lose this battle.
Yeah, so just for this patient, that's what we did. We got the acute glycemic problem under control. Then we sat with the relatives, and that's very important. No point just telling the patient that these are the group of drugs where it will go up. This is how you monitor your blood sugar, giving them a chart, showing them how to monitor blood. So this patient, I remember, was on oral tablets, and he actually needed insulin even before he came into the hospital. So we initiated insulin. We taught him and his relatives the use of insulin, how to titrate the blood sugar levels, how to check the blood sugar levels. And I don't think he has had any marked hyperglycemia since his discharge. And I'm sure in the future that will stop or be a big way in stopping his further exacerbations.
An interesting thing, because you did the counseling for the diabetes and at the same go we did the same for COPD, and he suffered so much in this admission, his compliance with inhalers and the other medications with COPD has also improved.
Yes.
So it's a win-win situation. His COPD exacerbations have come down. He's taking his medications for diabetes and COPD regularly, and that's what we want for the patients who have this overlap.
That is so often we see that if you're complying, you understand something, then you automatically become compliant with other bits as well.
Correct. Bolanda?
Yes.
KC Das probably goes with the spirit of what not to do in diabetes, but we are here. We've not had anything to eat for breakfast, so we are all here to have some quick breakfast. So KC Das is an iconic sweet meat shop in Kolkata. Most people outside the city and the state would actually come here and buy sweets. You know, Rasgulla and Rasmalai is famous here. So what is your experience with Kesidas,
Well, I think
Kolkata?
born and brought up with K.C. Das. So Krishna Chandra Das, I think he is original founder of this. He had actually a scientific mind. He was the first discoverer, or shall I say, the first person to make the vacuumed Rasgulla so that it can be exported to Western countries as well. So this has stayed, and you know, in exams there was a joke that if you don't do well, you will get Keshidas. That means Rasgulla. That means zero. So that is what I know about Keshidas.
Correct, correct. So we'll go in and I'll sort of ask you a question and then you can maybe answer once we are in the middle of having some breakfast. So what is your advice to people? So people often come to me and say, I've got COPD, you're treating that. I also have diabetes, in which case I send them to you. But they also ask, can I not have one sweet a week or one sweet a day? What is it in sweets that is better than others? So maybe let's go in and explore and you can give us an answer.
That's best answered after I've had the sweet.
So Kolkata, exactly opposite to Kesidas is the Calcutta Tram Company, and I was reading up for our discussion today. The Calcutta Tram Company was actually registered in London in 1880, as long back as that, and you used to travel from Armenian Street to this particular place, and it would go through Bow Bazaar, right? And it used to be something which was very unique to Kolkata, still very unique to Kolkata. In India, there's only a few other places in the world which has the Calcutta Tram Company. So I know you've got a movie in mind, isn't it? A movie in mind when we talk about Calcutta Tram Company. So tell me about it.
No, I was going to say that, see, Calcutta is perhaps one of the rare cities, or perhaps the only city in the world which has got boats and ships, because it's a big distributary of a river. It has got an airport, it has got buses, cars, it has got tram, and it has got a hand-pulling rickshaw. I don't think anywhere in the world you will get combination of all of these together. And I remember my friend saying that their idea of luxury on a Sunday would be having sweets in KC Das, which we just had now, and going on the tram ride through the Maidan. So I think
It's a lovely ride, isn't it? I mean, going through on a tram has got this very nice, laid back, chilled out feeling. And now there are heritage trams in Kolkata. So people who come to Kolkata actually use this to go around the city. And believe me, it's one of the nicest ways to go around the city and see Kolkata.
yeah, I think so, because it is not as jerky, definitely not as jerky as the bus, and even less jerkier than the train. And at the same time, you feel that you're just passing in between without you know, the other signals and all sorts of things which accompany railways.
Sure.
So I think we come back to your question.
We've had our Rasgulla now.
You had your Rasgulla.
So our
your
question
question
now.
was, so your question was, a patient with COPD says, I've got diabetes, should I never have sweets? So we have moved away from that. So from the diet, and that's important. A lot of patients ask, and we have got a lot of myths as well as about food. So see, the basic thing is, you can have just about everything. You have to have a balanced diet. So there is nothing called a diabetes diet. So nowadays it has been replaced by the term healthy diet. So Diwali is coming, Durga Puja is coming, Christmas is coming, Eid has come and gone. Should we have sweets? Are you denying me the pleasure of having sweet on a religious occasion? So answer is no, you can have sweet. So if you have sweet, you have to cut down on your rice and roti for that particular meal. So then that balances the carbohydrate. So don't make it a regular habit. Otherwise, every day you end up having just sweets and no rice and roti. So the mainstay is reducing your carbohydrate, because we eat too much. So you can have rice, you can have roti. Some people say, I can't eat roti, can I have rice? Yeah, of course you can have rice. They both are same. So have rice and roti, small in amount. You have more of dal and vegetables. Any dal you can have underground, any vegetables you can have underground, overground. Few pieces of potato, yes, you can have that as well.
And what about fruits, Kolkata? That's something that I get asked very often.
So fruits, you should be having fruits. So what I say that you should have 2 fruits a day. You can have any fruit. And people say, what about mango and banana? You may have that as well. So half a mango or half a big banana, you can have that. That will be considered as one fruit.
Right.
So one fruit is one guava, one apple, one orange, half apple, half mango, half banana. So that's one fruit. So you can have two types of fruits every day. You should have.
All right.
Fruits have got sugar in it, but they've got a lot of good things so that diabetes patients should not be denied. So the answer to your question, can I have sweets? Yes, you can have sweets, but when you have the sweet, don't make it a daily habit. When you have the sweet, you should have less of your rice and roti for that particular meal and just walk 10 minutes extra to counteract the effects.
No, that's grand. I mean, that's new learning from me. I'm sure a lot of the audience that's listening to us today, it's new learning from them. And it will give me comfort because I cannot just send a patient to a diabetologist or an endocrinologist to ask whether they can take fruits or a sweet a week. So it's comforting to know that they can, but important that they also see a dietitian in the loop and make sure that they're doing the right thing, isn't it?
Yes, true.
Is that yeah?
That's true. That's true. Right. So what I've said is just a brief idea. And for those who are non-vegetarians, I say you should have fish every day. It's very good. And chicken and egg also you may have at least twice a week. So previously egg with yolk was a taboo, but nowadays they said it isn't. So you can have up to 2 or 3 times a week. You can have egg with yolk as well, even in diabetes.
And does this change if you have chronic kidney disease with the diabetes?
Yes. So I think in the past, there was a vogue of severe protein restriction in kidney disease. But again, so protein restriction in the Western world is probably makes sense. But here, if you see, most of our patients don't take that much of protein. So they're already protein restricted. So now that has come down. So only if you have advanced chronic kidney disease, you have some sort of protein restriction, that 2.8 grams per kilogram body weight. So for a 60 kilogram person, it will be 48 grams. And I can tell you, a person walking in the street, more than 50% don't even take that. So we are moving away from severe protein restriction because that it's in itself can be bad.
Grand. Thank you.
Raja, this is the memorial, not memorial, the famous memorial, which you can call famous and memorial, Victoria Memorial, the iconic structure in Kolkata. If you come to Kolkata, if you don't stand here and you don't take a photograph, you have not visited Kolkata.
Correct. So our own Taj Mahal, isn't it?
Yes,
Kolkata?
yes.
Our own Taj Mahal. So just another important and interesting bit of information I found out that this was built for Queen Victoria, as the name suggests. Started in 1921. So we finished 100 years of Victoria Memorial last year. And the fact that this is the largest single monument that's ever been built for a royal anywhere in the world, Kolkata. Yeah, so that's a huge compliment. Right. So coming back to our academics and our discussion, which we left unfinished. So Kolkata, I remember another case, and we were discussing that in the car a little while ago. So I'll let you start off and then we'll discuss the case.
Because you had mentioned about a patient who had pre-existing diabetes and had recurrent episodes of COPD necessitating admission. I remember a case, and you can rejig your memory. So this was a roughly around 56-year-old gentleman who did not have a history of diabetes before, and he checks it once a year and said that my sugar readings were fine, I have not had diabetes. And he got admitted with COPD. Now, it's very difficult to single out this patient because there are so many patients who come with COPD and never had any history of diabetes. But this gentleman did not have any history of diabetes, and he got admitted. And although the initial blood sugar levels were around 100, 105, 106, but then his COPD began to worsen, his pneumonia began to take a stranglehold, blood sugar began to shoot up, and steroids were started for his bronchospasm as well, and then his sugar levels really go up. You might remember because I think he had twin sons, and both of them are doctors as well.
Correct. So I remember the gentleman, Kolkata, and like you said, this is the problem both of us face often. So this gentleman had no previous history of diabetes, and one of the challenges that we faced was the family thought that we had actually taken away one disease or controlled one disease, which was the COPD, but given him the diabetes. And that's a question that is often faced. The fact that you have to use steroids in these individuals to quell the inflammation, to control the inflammation, and the family thinks that the sugar, which now increases into diabetic zones, is something that's now been given to them by the treating team, by the doctors that are around. And I know from you that you check the HbA1c in these individuals and you have certain cutoffs which tell you whether this person was a latent diabetic, a diabetic who has a family history, who would have had diabetes at some point of time in life anyway, but now has developed diabetes because of the start of the steroids. And there are some people who have steroid-induced diabetes. So is it important to distinguish between these two groups? And if it is important, how do you do it? And what would you do differently in these two groups?
Yeah, so that's a crucial point. So here, HbA1c, I always emphasize that whenever a patient is admitted, if there is hyperglycemia, what is hyperglycemia? Any blood sugar reading of more than 140, you will treat it as hyperglycemia. If you have that, you must check the HbA1c. For this person, we checked it and it came back as 7.8. So he was having diabetes, which had existed for at least a period of 3 months prior to admission. And now it has been unearthed. Now, when the blood sugars go up, I make it a point to tell the patient and the relatives that, look, there are many causes why the blood sugars go up. One is that he is lying in bed, his illness. This might be pre-existing as evidenced by the HbA1c. And lastly, and I give it as the last one, is the steroids that we are giving. Please understand that the steroid is very important for him to get better. But we have to give him, that might get his blood sugar up, but we'll deal with it accordingly. Now, steroid-induced hyperglycemia, the management can be quite tricky as well. You will find a dearth or scarcity of guidelines for steroid-induced hyperglycemia. I think the best one is the Joint British Society guidelines. Sure. With the COVID also, the Indian government has come up with guidelines as well. So somebody who does not have diabetes at all, now given steroids, sugars have come up. If it is mild, by mild I mean it's less than 250 or 220, then we can give something like DPP-4 inhibitors, which work very well in this situation without causing hypoglycemia. If the levels are higher, then we have to look at other medications. In an outpatient basis, we can think about starting treatment naive patients on gliclazide. Right. So we can start with 40 milligram, 80 milligram and go on increasing it. Doesn't work, then insulin. For patients who are already on medications, you have no choice but to initiate insulin. And I'm talking about outpatients. So insulin, how much? So if we are underweight, elderly, or you are needing less than 40 milligram worth of prednisolone per day, then you can start with 0.2 units per kilogram of insulin, a long-acting insulin, along with their diabetes medications. If they are requiring more than that of insulin or they are obese, then you start with 0.3 or 0.4 units per kilogram. In hospital, you have no choice. Mild hyperglycemia around 220, you can think about DPP-4 inhibitors for newly diagnosed diabetes. But if it is more than that, I go in for basal bolus insulin regime. So 1 basal insulin and 3 times bolus dose of insulin.
And what I have seen, Kolanda, is that you continue the insulin when they go home and continue on oral steroids, and then you shift to an oral hypoglycemic after, isn't it?
So I take the call at the time of discharge based on the discharge blood sugar levels, based on their HbA1c. Right. So if the HbA1c is more than 9%, that means they must go on insulin. Right. If the HbA1c is less than 7%, I may take a call and not give insulin on discharge, but give them medications which taper off every 5 days. Right. 7 to 9 is a gray area which will depend, which I will have to decide on case-to-case basis. Sure. And here comes the other problem is, a lot of patients ask me, and in fact, many doctors also ask that, and you had raised this question as to whether inhaled steroids, we know the oral steroids begets hyperglycemia. Does inhaled steroid do it? Now, there have been conflicting evidence about the inhaled steroids, but I think the most recent one, which you have already quoted in 2021, last year, that showed that there was no increase in incidence of diabetes or hyperglycemia with the inhaled steroids. But the question is, do we take the inhaled steroids correctly? And you will be the best person to answer. Sure. What are the perils? Where do we misuse it? do we use it well, and do we misuse it? And if we misuse it, how do we misuse it?
Sure. So I think the oral versus inhaled steroid question is something we have managed to answer reasonably well. And if you take a pragmatic view, Kollanda, the fact that inhaled steroids might push the sugar up a little bit has to be balanced against multiple courses of oral steroids over a year. And we know that even if it's short courses of oral steroids, courses which last about 15 days on each occasion, that results in lack of balance of sugars far more than inhaled steroids do. So I think in patients who require inhaled steroids, and I'll repeat myself, patients who are exacerbating on multiple occasions, require one hospitalization due to an exacerbation, patients who have a raised eosinophil count when off steroids, oral steroids or IV steroids, are patients who need to go on to inhaled steroids. The question about diabetes probably is a smaller question when you think about side effects. We are more worried about inhaled corticosteroids causing pneumonias in patients with COPD. There's quite a bit of data about this. There's conflicting reports about whether fluticasone causes more pneumonias as compared to budesonide and other steroids. And there's a little bit of data that fluticasone indeed causes a bit more of pneumonia as compared to what inhaled budesonide does. The more important question also is about fungal infections in the mouth when you take steroids. And again, people who are diabetics will be more prone to having oropharyngeal candidiasis as compared to others. So counseling about washing the mouth, gargling post taking inhaled steroids is very, very important in these individuals and something that needs to be remembered. I think the important question is to follow the inhale regime that the patients give you. Very, very important to do that. Making sure that they are taken in the right manner. Washing your mouth post the procedure. All of these factors are important when you take a call as to whether the steroids A are needed and B, whether the steroids are resulting in side effects and how to avoid them and treat them. So I think those are important questions.
I think it's an important point you raise, because inhaled steroids, and if you don't wash your mouth, you're ingesting it. You're ingesting the steroid again. That will beget it.
Correct.
So taken appropriately, taken correctly, should not really worsen it. So it's quite interesting to see the viewpoints differ, because your viewpoint is about begetting pneumonia. My viewpoint is getting blood sugar level. So I think from my side, a correct demonstration of use of the steroid, choosing the right patient for the inhaled steroids, I mean, correct choosing the right patient, correct demonstration of the technique, and washing the mouth after taking the steroids, all are crucial. And because, as you said, it also begets oral candidiasis as well.
Sure. The other point I wanted to raise, and we've got plenty of stalls. The stalls have moved away, but you know, there's a lot of chulha smoke, there's a lot of biomass exposure, especially in rural India, but also in urban cities.
Yeah, funny you should say that. I can see that in the distance. Can
Correct.
you see that? And
Correct.
this is exactly what happens. And not only in rural, people think it's rural, it's as bad in the urban areas as well.
Correct. Correct. So I think a lot of the questions that get asked is biomass bad for you? Is biomass causing COPD? Is air pollution causing COPD? And I think we've got good quality evidence now that biomass exposure actually results in 3 times more COPD as compared to cigarette smoke COPD. So just think of that. When we learnt our medicine, Kollanda, we were told that cigarette smoking is the only cause of COPD. We now understand that it's also the chulha smoke, it's the air pollution which results in COPD. The interesting difference between air pollution and biomass-related COPD and cigarette smoke-related COPD is that cigarette smoke COPD causes more of emphysema.
Okay.
Biomass-related COPD, air pollution-related COPD causes more of bronchitis. So chronic bronchitis symptoms, cough, phlegm, expectoration is classic of biomass-related COPD. Shortness of breath, exertional dyspnea without very much of cough and expectoration is classic of cigarette smoking. So how is that relevant to our discussion today? 2 important points. One, biomass-related COPD seem to cause more of an inflammatory surge as compared to smoking-related COPD. So all the complications we spoke about, obviously diabetes, but also the heart disease, the kidney disease, etc., seem to happen more with biomass-related COPD, and hence the inhaled steroid probably is more relevant in biomass-related COPD as compared to what it is with smoking-related COPD. So there are a couple of studies which have shown that if you make a head-to-head comparison between triple, that is ICS plus LABA plus LAMA, versus LABA LAMA alone, the control is as good with the triple versus the double in emphysema, whereas in patients who have chronic bronchitis, you would want to add in the inhaled corticosteroid. So that's something which is relevant, important to our discussion. Also may be important from a diabetes point of view, because when you see your patients with diabetes and you find out the patient has COPD, you would want to know whether this is biomass related COPD or whether this is smoking related COPD.
On that note as well, so what you are saying is biomass is mainly inflammatory, so that would therefore the inhaled steroid would work. So am I wrong in assuming that these group of patients may require oral steroid courses if they have exacerbations as well?
Correct.
So that makes relevant to me. Correct. Because then these group of patients due to air pollution induced COPD are likely to require steroids and therefore likely to have hyperglycemia as well.
So these are the gold D COPDs. So that's the exacerbation population of COPD. They are more, so smoking related COPD is more gold B COPD, which is the stable COPD, whereas gold D COPD is the biomass related COPD. And here multiple exacerbations, multiple courses of steroid, the ICS to maintain disease in the stable state, all of these factors become very, very relevant.
So I think as far as air pollutants and diabetes is concerned, there is no clear proof as such that it begets hyperglycemia or it worsens the diabetes as such. But there seems to be some observational data that particulate matter, which we call PM, so if it's less than 10 microgram, more exposure to that and nitrous oxide gases, that does lead to significant amount of hypoglycemia in the long term. But as I said, we don't have any proof, definite proof yet, clinching proof yet. But it makes sense from what you're saying, because if that begets inflammation, and that's a common thread between diabetes and COPD, if it begets this, there is a good chance that it might beget diabetes as well. So I think we should ask that person there or educate that person there how to not create the pollution.
And you know also about aerated kitchens, you know, in the rural areas, they might have to use chulha as a matter of compulsion, but trying to encourage them to shift to LPG. The government has made so many schemes now to try and get rid of chulhas, biomass and go to LPG. That's important. Well ventilated kitchens are important, making sure that there is a chimney or even a kitchen window outlet in the kitchen is something which is very, very important. And things we need to think of when we think about prevention. We've spoken a lot about treatment, but prevention of COPD, better air quality, trying to get the PM 2.5 and the PM 10 down are all factors which prevent COPD along with promoting smoking cessation. So I think those are also factors.
And do you think the mask, which is now in vogue post-COVID, that might play a role?
It might do. There is a little bit of evidence. It cuts out the PM 2.5 and more so the PM 10 particles. But you know, all of us know that the mask is difficult to put on. And it's difficult to put on for long periods of time. So I think prevention, improving air quality is a more important priority as compared to self-protection and wearing the mask. People who are allergic, people who have pollens, dust, smoke as a trigger, which is a lot of people, they probably would do it when they are in outdoors and polluted atmospheres.
That's an advice we can give actually, those who are prone to develop this allergic, atopic individuals, that they can have this as well.
Kulanda, wonderful morning spent with you. We are now at our place of work, which is CMRI Hospital. So let's finish off with some carry home messages for people who are hearing us or will hear us in the coming days. So from your perspective, what are your carry home messages for the overlap phenomenon of diabetes and COPD?
So before that, one confession, instead of having one rasgulla, I had two. So carry home message number one, cut down on the amount of sweets. You don't have to completely stop it, but cut it down. So now coming on a serious note, as far as the take home messages from the COPD diabetes perspective, and I can only speak from the endocrinology or diabetology perspective, is that there is a common thread which is inflammation. There is another common thread which is pollution. Perhaps the data amongst Indians is higher, that we have got more diabetes patients developing COPD and more COPD patients developing diabetes. So high index of suspicion, checking for blood sugar levels for each and every patient with COPD who is admitted to hospital, keeping a note and educating patients that steroids can cause hyperglycemia, clear guidelines to the patients regarding steroids and hyperglycemia, good management of blood sugar levels during hospital admission with the basal bolus insulin regime, with an important, very clear discharge guideline to the patients so that they don't land up with either hypoglycemia or hyperglycemia. Good education regarding blood sugar monitoring with the glucometers at home, which I think is another vital important thing. So overall, diagnosing it, preventing hyperglycemia, preventing hypoglycemia, appropriate education to the patients and the caregivers alike. So that's from my side.
Yeah, wonderful messages, Kolanda. So I'll just extend what you said. I'll take one step backwards and say that one of the things that have been really fulfilling working with you, Kolanda, is the fact that while you manage hyperglycemia caused by steroids well, you did not put steroid phobia into the patient's mind. And I think that's an important message. The fact that steroids in an exacerbation of COPD is something that is life-saving. And there can be nothing more important than parenteral steroids, oral or IV, during a COPD exacerbation. I've had multiple patients who've come to me and said, "Doctor, you've given me steroids. I'm in an exacerbation. I won't take steroids because I know diabetes gets worse or I can get high sugars when I take steroids and I won't take them." So that's a roadblock. And like Kolanda said, and we have said this throughout the morning today, that it's important to have the right perspective. Steroids are important if they need to be taken. The first decision is, do you need steroids? If you need steroids, you need to have a happy endocrinology, diabetology colleague with you who will control the sugars in the right manner in the way that Kolanda has described this morning. The other important message from my side is about inhaled steroids. The fact that inhaled steroids are appropriate in about a third of patients. 30% of patients with COPD will need an inhaled steroid. So it's important to select those patients carefully, because in those who don't need inhaled steroids, giving inhaled steroids might mean side effects like pneumonias, like oral candidiasis, or even with very little evidence, but some anecdotal evidence that sugar control might also go all right. However, in the 30% who need the inhaled steroid, the inhaled steroids and other inhalers need to be taken regularly. They need to be taken with the right technique, and all the good lifestyle guidance that we talked about. Drugs is one facet. Rehabilitation, physiotherapy is the second aspect. Vaccination, we all hear about COVID today, but vaccination for influenza, for pneumonia, even pertussis now, are important additions in the gold guidelines for management of COPD, and these need to be remembered. We spoke today about smoking cessation, very important to do that, but also hopefully our discussion today brought into light the importance of biomass exposure, the importance of air pollution, etc., in the causation of COPD, and these different causes need to be kept in mind, not just from a COPD perspective, but also from a multi-system perspective, from a diabetes perspective. So those are important things to remember. I think it's important for all of us to say that, like Kolanda said a little while ago, any patient of COPD, be it in the OPD or be it in the IPD, needs to be screened for diabetes at some point of time, because there are implications about treatment of one disease which impacts the other. And I think for all my outpatients today, I would get a blood sugar checked at some point of time. I would get an HbA1c checked at one point of time, because like we have said, we are the global capital, not just for diabetes, but also for COPD. I had a lovely time, Kolanda. Thank you very, very much for the lovely time. I enjoyed my time at KC Das and having the rasgullas there. So I hope we can do this again at some point of time in the future.
So did I.